the National Imaging Facility podcast. On this episode, we talk to Dr. Bart Bolsterlee and NIF Fellow Dr. Michael Green from NEURA. Bart is a mechanical engineer and a biomedical engineer who studies the generation of force and movement in humans. His speciality is the use of imaging technologies such as MRI and ultrasound to study human movement biomechanics. His current work at NEURA focuses on the use of diffusion tensor imaging, or DTI, which is an MRI technique used to measure muscle structure. Joining today's discussion is Dr. Michael Green. As a NIF Fellow since 2009, Michael works with researchers using the NEURA 3T MRI system, including access, technical advice, data analysis, and imaging procedures. Michael is a physicist and has been working in MRI for over 10 years. His research interests focus on MR diffusion imaging and analysis, as well as human brain MR elastography imaging. We hope you enjoy this discussion.
Yeah, so my name is Bart Bolsterlee. I'm a research fellow at Neuroscience Research Australia. I'm a biomedical engineer by background, and my research is on imaging the structure of human muscles using advanced MRI techniques, including diffusion tensor imaging.
So my name is Michael Green. I started at NEURA when it was the Prince of Wales Medical Research Institute doing MR elastography research for Lynn Bilston's group. Yeah, and I was in a completely different realm before that doing physics. But now my role is to support researchers and help with analysis and access to scanner and making sure researchers are actually acquiring the data that they need to answer their research questions.
Can you tell us a bit about the MUGgLE Study?
Yeah, so the MUGgLE Study, MUGgLE stands for muscle growth in the lower extremity. So it's an NHMRC funded study on looking at muscle growth in typically developing children, as well as children with cerebral palsy. So in this study, we will scan the lower legs of over 300 children. And it's a longitudinal study, so they will be scanned 3 times with 1.5 years in between scans. So we analyze the images to look at individual muscles and how they change in size and structure over time. So the key measures we are getting out of this study are not just the volume of muscles, but also the fiber orientations within muscles, which is a key determinant of the function of a muscle. And we also look at the fat content, which is a compositional feature of muscles that's quite different between diseased muscles and healthy muscles.
So this work was between the Cerebral Palsy Alliance Research Institute and UNSW and NEURA. I've got a few stats in front of me about cerebral palsy that are quite interesting. So 1 in 700 babies are born with cerebral palsy, and it's the most common physical disability in childhood. So the impacts of your research have real implications for children growing up in Australia.
Yeah, we hope so. So this is very much a fundamental research study. We don't have any direct clinical outcomes that we are assessing. But what we do know is that with children with cerebral palsy, which is the leading cause of physical disability in the Western world, the outcomes are usually pretty poor. 1 in 3 children with cerebral palsy cannot walk, for example. And we know that has got something to do with disordered muscle growth. It's obvious from cross-sectional studies that there are quite some differences between the muscles of children with cerebral palsy and their typically developing peers. But no one has really studied this longitudinally, so we don't actually know when these changes occur. And we believe that information is necessary to develop new treatments. At the moment, there's no treatment, there's no cure. Often these children undergo have quite severe interventions, and they get either botulinum toxin in the muscle to reduce activity of their muscles. Sometimes they have multi-level surgery. And all of these interventions change muscle growth, but it's quite poorly understood how exactly and what the functional consequences of that are. So we are trying to develop imaging methods to be able to study that. And we are generating the first data to give a comprehensive picture of how muscles actually develop, usually, and how that's different in children with cerebral palsy.
Michael, how do you work with a user like Bart to get this information together?
I was just thinking, and I thought about this a couple of times with Bart and Rob Herbert's group. I've learned a lot from them as well, right? So, I mean, some of the kind of bespoke tools that you've made, Bart, in order to create those cool images, diffusion images. So, I mean, I've done a lot of diffusion analysis and helping researchers acquire diffusion images and analyze their data using software, some great software that's out there. And a lot of that's focused on brain. And a lot of the software is dedicated for brain analysis and looking at brain volumes and connectivity between different parts of the brain. I mean, and then Bart, you had that issue right from the start. It was like, wait a minute, I'm doing muscle. And it's a completely different tissue, in some ways more aligned fibers within the muscle, but actually a lot of the software wasn't lined up to analyze that sort of data properly. So Bart's had to hack a lot of it, make your own software itself, right? Writing in MATLAB, is that to make those images? So
yeah.
I was just thinking that I've learned a lot from Bart's group and, and Rob's group. And so, we got the ball rolling, acquire images, and here's some software that you could use. And then they realized that actually a lot of that stuff they had to change in order to get the results they needed.
Yeah, that's right. Like many of the tools that are out there were developed for the brain, because I would say that 99% of diffusion imaging is to reconstruct the neuronal architecture of the brain. We had to adapt that to both the acquisition protocols as well as the image analysis techniques to accommodate the specific features of muscles we are interested in. And that meant that we had to develop most of our own algorithms, which I think is really nice, because you really understand then what exactly our analysis tools generate. So what kind of information they give, what the limitations of those measurements are. Whereas if you just put data into some existing tool, then it's often a bit of a black box. You don't really know what comes out, what comes in. And yeah, I think that it's been challenging, but it's been very interesting as well. And it's nice that we can now do these kind of measurements at scale to actually answer like really what we think are really important questions about growth of muscles. So it's been a bit of a process. I've been working at Neura for the better part of 8 years now on this, and it's really nice to see this sort of from the first proof of principle demonstrations being taken to large-scale research, and hopefully into clinical practice as well.
And it's getting recognized, right, Bart?
Yeah, definitely. Yeah, absolutely. Yeah, so we've developed and published some algorithms that now several groups around the world are using, and people know how to find me. So I often have give advice to others who want to use these measures as well. It's nice to see that more and more researchers have access to MRI facilities as well. And especially the diffusion tensor imaging sequences are being used more and more as well to study muscles.
Yeah, you're right. I mean, you're right about the analysis stuff is a bit of a black box. Some of these tools are so well written and packaged up that you can just put in your data and stuff comes out the other side, and that's fine. And most of it works really well. But it's also the case. And the acquisition side of things, you're right, but I'd sort of forgotten about a bit of that. A lot of the diffusion acquisition, actually getting the images from the scanner, is set up for getting brain. So there's a lot of little tweaks that need to be done if you're actually going to do acquired diffusion images for leg muscle. I mean, they're completely different parameters. So there's a fair bit of that going on too. I'd almost forgotten about, wasn't there? There was a lot of...
Yeah, definitely. Yeah, and we've had some really good help from the Philips clinical scientists who are helping us out at Neura and optimizing our protocols. That is Ian Ball at our
Ian Ball particularly.
Yeah, and he's been fantastic in helping us out optimizing our imaging protocols specifically to get like the best images possible for diffusion imaging of skeletal muscle.
And in good time, right? These are kids and babies, to make sure that we're acquiring good images that aren't going for 30 minutes.
Yep. Yeah, exactly. Like typically when we started doing this, we always had to book for about an hour. And now we usually get in and out of the scanner within 20 to 25 minutes. So that's especially for pediatric imaging. That's very important. It's very difficult to keep children in the scanner in the first place, and they might be distracted by a movie for around 20 to 25 minutes. But after that, you're inevitably going to get some movement artifacts, especially in the younger kids.
So Bart, through your work, you've dealt with a lot of child subjects. So what's the process when you're bringing in lots of different children? They say never work with animals or children. How does it work when you're bringing them into a clinical environment to do something highly technical, perhaps sometimes for some length of time?
Regularly scan the legs of children, typically aged 5 to 18 years old. Very much depends on the age of the child and the levels of anxiety in the child. Typically with the younger ones, like around 5-6 years of age, they need a little bit more time to be comforted. So usually what we do when they come to neuro imaging is we show them the scanner. So we just take them into the control room and they can just have a sneak peek into the scanner so that they know what's going to happen. We usually play the sound, so we have some recordings. The scans can be loud, that's sometimes a bit intimidating. So before they actually go into the scanner, we just play that on our phones or on an iPad, so they have an idea of what the sound is going to be like. We always allow for plenty of time for the kids to ask questions and get comfortable with the idea that they're going to be lying in that scanner for around 20 to 30 minutes. Playing the statue game. So far, we've had hundreds of kids in our scanner now, and I would say that in at least 95% of the time, we actually get very useful data out of it. So there are occasions when children don't like it, they feel intimidated by the scanner noise. They always have a button in their hand that they can press in case they want to get out. Usually when mom or dad is around, they can sometimes go into the scanner and comfort them to continue going, and usually that works pretty well. So I guess the key is just to allow enough time so they don't feel like they're being rushed, and just to prepare them a little bit for what's coming. But overall, I think most kids who participate actually are quite excited to be part of research. It's highly technical equipment. It looks pretty cool with a ring of light on the outside of the scanner. So they feel like they go into a spaceship, and they're actually pretty excited about it. Yeah. We've also done some studies on infants. So we've had probably around 8 to 10 infants in our scanner now. So we do it below 3 months of age. For that, we use a technique that's called the feed and wrap technique. So the idea is that you hold off feeding the baby just before the scan, so that they're quite hungry. Then they have a feed with their mum, and then they usually after that, or you give them some time, they go to sleep. But once they go to sleep, you swallow them tightly, and you put them in the scanner. And so far, we've had at least like 10 to 15 minute windows to get some good images.
A lot of this stuff, I'm not saying it couldn't be done in a clinical environment, but I think one of the advantages we've got at the moment at Neuro is that the MR is only for research. There's no clinical scans going on. We're down the hill from the hospital, and we haven't got any clinical scans going on at the moment. And it allows for stuff like this to happen, I think. I mean, there was a lot of planning ahead of the MUGgLE study, right? But also the baby one as well. I mean, there was a lot of preparation for that and making sure that this is possible. There's other rooms in which you can settle the kids and the babies before they go in. I'm not saying it can't be done in a hospital clinical environment, but it's probably a pretty big advantage that Neura, as part of the UNSW NIF nodes, got this there, I think.
Yeah, absolutely. Yeah, especially because it's we're quite flexible with timing. Of course, babies don't like to be scheduled very much, so it's nice that we have the option of allowing a bit of time for the baby to fall asleep, and when they do, we can quickly put them in the scanner. In hospitals, it's usually very very busy, those scanners, so they get like maybe a half-minute slot, sometimes even 15 minutes if they're lucky. And the success rates are a lot lower there with scans because it's just really hard to get babies to sleep at the time that you want.
So Bart, your article titled "A New Framework for Analysis of Three-Dimensional Shape and Architecture of Human Skeletal Muscles from In Vivo Imaging Data" was selected by the American Physiological Society as the March 2022 APS Select article. Do you mind telling us a little bit about it?
Sure, yeah. So I published an article in the Journal of Applied Physiology, which is one of the leading physiology journals in the world. It's published by the American Physiological Society, and every month they select one article to be highlighted. This month they chose my article, so it was on a new way of analyzing MRI and diffusion data from skeletal muscles to look at the three-dimensional structure of muscles and how that changes with a range of conditions. So the paper came with a toolbox as well, with publicly available algorithms coded in MATLAB that others can use as well to use those analyses in their own for their own research.
And I still find it hard to believe that no one really knew the architecture of the leg muscles very well, right?
Yeah.
Even before, just amazing.
Yeah, so most of anatomical knowledge about the structure of muscles comes from textbooks that are based on dissections of cadaver legs. So cadaver legs are usually from older people who've donated their body to science. So we have sort of a rough understanding of the fiber structure within muscles and how that's different between muscles. But it's been very, very difficult to get that information from living human muscles. Muscles is one of the most adaptable tissues in the human body. When you exercise, they get bigger. When you lie in the bed for too long, they get smaller very, very quickly. So it's really important if we want to understand like how muscles adapt in response to various stimuli. It's really important to have in vivo imaging methods, so methods that can be applied to living humans. So what has been used in the past was mostly ultrasound. So ultrasound is typically two-dimensional. It's you can only really use it on muscles that are quite superficial to the skin because the ultrasound waves don't penetrate the body very deeply. And with MRI and diffusion imaging, we've now got a technique that allows us to look at whole human muscles in 3D while in living humans. So that really allows us to study these processes in great detail. And it led to already some discoveries about, for example, the structure of the soleus muscle. We published a paper on that a few years ago. For the first time, really describing the complex fiber structure of this muscle and how that changes when you stretch out the muscle. So we really applied this technique for both generating anatomical knowledge to understand the physiology of muscles when they contract or when they lengthen, and also to investigate how muscles change in response to certain diseases.
How many people are involved in one of your studies, Bart?
It depends on the scale of the project. I've done studies just mostly by myself, but nowadays we usually have, for example, for the MUGgLE study, which is the first sort of like a larger scale study, we've got a team of 10 to 15 people working on it, all the way from study coordination and recruitment to actually guiding the children into Neura, into the scanner, setting them up on the MRI bed before their scan, to people working on the image analysis and streamlining that part. And then finally, of course, the study leads who have to interpret all that data and make sense of it and publish it in in a way that the information from the images is useful to understand something about muscle growth.
It's probably about 15, isn't it, Bart?
Yeah, at least. So they're not all full time. It's
No.
Most of them are part time or casual workers. But all up, there's around 10 to 15 people involved, including also biostatisticians, imaging experts. So Lindy Ray is involved as well. So it's definitely a multidisciplinary team. Yeah.
And also, Alex, they can't just, half of them access the scanner, let's say.
Yeah, about half of them, I think, have done their safety training.
So they need safety training. So I run the safety training courses and just schedule those in when needed, really. There's often different people and different students coming into different projects each year and things like that. So there's new people that need access. They need to make sure that they understand how to work around MRI.
What is your role working with users of National Imaging Facility capabilities?
The images that they acquire from the MR scanner are not usual clinical images that they punch out in hospitals and get patients through quickly. They're tweaks on the standard images that you acquire. So we want to make sure that the researchers are using their time in the scanner efficiently and getting the images. We spend a lot of time acquiring images before they actually kind of arrive to do their first one. We do a lot of development scans. And even when we've got the new scanner, we do a lot of development scans to make sure that the images that we suggest they acquire are not only short, so they can fit in participants within their hour or however long they've booked, but it will give them the results that they want to answer their questions. So that's probably the biggest thing, I think. Make sure that they acquire the data properly. And then there's a huge amount of other things I can go into in terms of, your researcher wants the data. So there's a lot of extra infrastructure that's also costly as well that is required for the scans to go to servers, and then the researchers can grab them quickly and then do their analysis. And even what they're doing their analysis as well suddenly generates a whole lot more data. And not all groups require this, but some research groups require space for their data to sit and have some sort of decent sort of folder structure so that they know where their analysis is up to. These sort of problems, I used to think were kind of unique just to our node, but I've learned with time, it's not only unique to our node, not only unique to NIF nodes, but across the world doing big data analysis.
So would you say it's not a one-size-fits-all situation, and it's your job to tailor outputs to meet their needs?
Yeah, absolutely. I mean, there's groups that come in, they need advice on how to analyze their data. I mean, and I can do that sometimes, not all the times, but I can find out. Other groups are really great at, they know exactly how they want to analyze their data. That's fine. There's other groups that want to know, they know exactly how they want to acquire their data. We can give them tweaks on that. I mean, the Philips clinical scientist, we've got a Philips 3TMR scanner, and their support's amazing in tweaking and making sure that our scan is sort of state-of-the-art, doing state-of-the-art imaging. And then there's other groups that require rooms and space just within our facility so that they prepare some of the participants before they come in. We can do all that outside of it. So we're not actually churning through money, using up the scanner area, taking blood samples and measuring kids' heights and putting them on beds and putting them on a bed for them to come into the scanner so that they come straight through. So there's lots of that. I mean, and then there's also, planning up, not unlike the people in the group, Bart's group, in that they've got the ball rolling and they can roll with it really easily and do great research. Having been supported early and supported a little bit, but continuing to use the scanner in great ways without heaps and heaps of help from us. So,
how would someone go about getting access to imaging capabilities at NEURA?
How to get access to the scanner? How do you actually jump on there and acquire images to answer your research questions? And talking to us first. The first thing you do is you talk to us first, and we can talk to the radiographer and say, what do you want to do? What sort of images you might acquire? Some people, often researchers just say, let's get some MRI images, and that's kind of it. And not surprisingly, it's much more complicated than that. But the idea that actually you might need to set aside 50 minutes to acquire images and things like that. You need participants going in and out. You might need to actually book for an hour and a half, and suddenly that becomes quite expensive. You need to make sure that your ethics is in place before you do scanning. You need to make sure you know where your participants are going to arrive and park. And it sounds ridiculous, but how do they get there, and where will you be when they arrive? And
something that's often underestimated. So when there's more and more researchers interested in doing imaging without necessarily having the expertise, but they've seen other groups, like use imaging, or they know how they can, what sort of information they would like to get out of images. So they write it in their grant proposals, they get money to do it, but they don't actually necessarily know how to do it. And that's, I think, where facilities like NIF and neuroimaging are essential for. Sort of streamline that whole process from getting the images that you need out of the scanner to getting the measures that you're interested in from your images. So that requires a lot of expertise, and often when they leave that just up to students to figure that out, because the chief investigators don't necessarily have that expertise themselves, you find that it can be quite challenging. You need some highly technical support like that NIF can provide to get any useful data out of it. I think people who've never used a scanner think of like Michael says, they come to a scanner and say oh yeah, but you just want to get some MRI scanners, some MRI scans of the leg. But there's so many options and so many things that can go wrong along the way. So many strange artifacts that can appear on your images. So it definitely requires a lot of expertise and often some pilot scans to set up the protocols for, especially for in research settings where you don't necessarily do the standard things, but you really want to push the boundaries. I think it's often underestimated how much work it actually is, and how much expertise is needed to get useful information out of images.
So when researchers are in that position, they should talk to someone like you, Michael, to give them an idea about what is possible, but also the things that they need to consider before they commence their imaging processes?
That's usually the way it goes. Yep, myself or Lindy Ray, who runs neuroimaging, we have a chat to people first, and I suppose more often than not, what happens is we go, no, you could do this. And then they go, oh, actually, it's not just images we're getting here. We're actually getting some pretty in-depth information about more information. I think that's often the case. Geez, I reckon it might be maybe 90% of the time that researchers start and they just want to get some structural images of the brain, say, and they can get volume out of it. They can calculate total brain volume or something. Usually by the end of it, and we can squeeze in lots of different image acquisitions into their allotted half an hour or something, and they'll get diffusion data as well that they didn't know that they could get more information out of, and other sorts of image acquisitions as well. They often go away 3 or 4 images within a session. There's so much different research going on. I mean, I've worked on studies and still working on studies looking at underage binge drinking and insomnia, sleep apnea, Williams syndrome. That's some of the stuff that I've been working on. Actually, probably the most interesting stuff most recently with the new scanner is we are making sure we're doing a lot of development, and still are, on acquiring images that are really good, that take as short a time as possible. And if you acquire for longer, you usually get better images, as long as the person stays still. In general, that's a bit of a sweeping generalization, but you can't do that. And so you can actually scan quicker and quicker these days. You can set settings to scan really quickly, but the images aren't as good. So at what point in the clinical world, this is kind of like, they just want a quick image, and most of the time they can diagnose from a quick image. In research, at what point, where is this sweet spot where you can acquire images and still get really accurate, reproducible data, making sure the data's good and reproducible. So that development's hugely important, I think, so that we can actually just say to researchers, do this scan. It takes 4.5 minutes, but it's great. You'll be fine. And it takes a lot of time to do that, but we're confident we've got those sort of images now.
Thanks to Bart and Michael for joining me on the podcast today. To keep up to date with NIF, follow us on Twitter, LinkedIn, Instagram, or Facebook. Or you can visit our website at anif.org.au.